Alright guys, so now we are going to discuss about the bones of the upper limb. Okay, so here you can see this is the scapula and this is the right scapula. As you can see, this is the medial border, this is the lateral border, and this is attached with the head of the humerus. So first of all, you have to prepare all the landmarks from all different, anterior side, posterior side. From anterior side, you can see this is the subscapularis fossa, subscapularis muscle is attached here, and this is the medial border, this is the lateral border, this is the you can see the suprascapular notch also here, this is the coracoid process. On the posterior side, you can see this is the spinous process, and acromion process is basically the continuation of the spinous process of the scapula, and clavicle is attached laterally with the acromial end of the scapula. Here you can see the supraspinatus fossa, the muscle attached here is the supraspinatus, which is one of the strong muscle of the rotator cuff muscles, and here is the infraspinatus fossa, and this muscle is infraspinatus here. And here is your glenoid cavity of the scapula, and head is fixed in glenoid cavity. So you can see the head is ball shape and this is a socket shape. So this is basically called as ball and socket joint. So this is one of major synovial joint. Because of only two attachments, that's why this is also called as simple synovial joint. So you should remember this is a simple joint. Okay. Then you see the humerus, you can see this is head of the humerus, and this is the greater tubercle, this is the lesser tubercle, this is the intertubercle sulcus. On the greater tubercle, the muscle attached inserted on the greater tubercle are the supraspinatus, infraspinatus, and then teres minor. On this lesser tubercle, because here you can see that on the lesser tubercle, the muscles inserted on the lesser tubercle are those coming from the anterior side of the scapula. So subscapularis originating from this part and inserting on your lesser tubercle of the humerus. Then you can see the deltoid tuberosity at the lower end. You can see the medial epicondyle, its site of the attachment of your flexors muscles. That's why repetitive flexion can lead to the medial epicondylitis, or it's common in the golf players due to the repetitive flexion of the elbow joint. On the lateral side, you can see this is the lateral epicondyle. So this is the site of attachment of the extensors muscles. So whenever you are playing the tennis or repetitive backhand shot, it may lead to inflammation of lateral epicondyle. So that is called as lateral epicondylitis or the tennis elbow. So here you can see the radial fossa and then coronoid fossa. This is capitulum, this is trochlea. On the posterior side, you can see this is olecranon fossa actually, and then you can see the radial groove also. Actually, these fossas are really important because they help in execution of the full movements, like you can see here. So this is anterior side. So now I am going to flex your elbow joint. So you can see the olecranon process and coronoid process of ulna is moving inside this coronoid fossa, and this head of the radius is moving inside the radial fossa. So these fossas helping in full execution of the flexion. And now I am going to extend your elbow joint, and you will see that olecranon process of ulna is moving inside the olecranon fossa. So this is the extension. So this is basically the primary function of these fossas. Secondly, you know that basically elbow joint is a hinge joint. It's moving in one plane like flexion and then extension. So it means there are strong collaterals, ligaments like medial collateral and the lateral collateral, or the ulnar collateral, or the radial collateral ligaments, which help in basically prevent the dislocation on the medial aspect or on the lateral aspect. And if we are talking about the clinical aspect, so you should understand, please, this is anatomical neck, this is surgical neck. So any fracture to the surgical neck of the humerus lead to injury of the basically the radial nerve, and person might have the wrist drop because this radial nerve is helping in extension of the wrist. Then on the medial epicondyle injury, it may lead to the ulnar nerve injury. On the lateral epicondyle injury, it may also lead to the radial nerve injury. Supracondylar fracture usually lead to injury of the median nerve. This is ulna. Here you can see the olecranon process. Here you can see basically the trochlear notch, and this is coronoid process. This is the radial groove, and at the lower end you can see this is the styloid process. So this is your radius. You see the head of the radius, the round head of the radius, and then this is basically wrapped with the annular ligament in the elbow joint. So this is the neck, and this is the radial tuberosity. At its lower end, distal end, you can see this is site of attachment of the carpal bones. You can see like scaphoid bone is present here, scaphoid and lunate also, and then this is your styloid process. This is basically the lateral bone. Radius is on the lateral side in your forearm. Then bones of the hand, you know that we have got carpal bones, 8 carpal bones, we have got then metacarpals, we have got phalanges. So the first carpal bone is, you see, which is basically attached with the radius, that is scaphoid, and this is like mini boat. Scapha in Latin, this is called as boat. So scaphoid, you see the boat shaped bone, this is scaphoid. Then lunate, you see the luna. So this is basically half moon. Luna in the Russian language is called as moon. So this is moon type. So this is the lunate. Then you see the triquetrum bone with the 3 corners, and then pisiform. This is also the sesamoid bone here growing within the tendons. So this is the first row of the carpal bones, and then in next row you can see again the trapezium, which is on the base of the first metacarpal. Then you can see the trapezoid, then you can see the largest carpal bone, the capitate. Then you can see the bone on the medial aspect with the hook, very important, clinically very important. This is the hook of the hamate. So hook of hamate can lead to injury of the ulnar nerve. So here you can see the metacarpal bones, and then we have got metacarpophalangeal joints. We have got in your thumb, we have got proximal and distal phalanges, but in other digits you have got proximal, middle, and then distal phalanges. These are bones of the foot. Here you can see the calcaneus. This is basically the heel bone. Then you have got talus, then you have got navicular, then you have got cuboid, then you have got 3 cuneiforms. This is on the lateral side. So this is the lateral cuneiform, this is intermediate cuneiform, and then you have got medial cuneiform. And then these are the metatarsals, and these are the bones of your toes phalanges. So proximal and distal, proximal, middle, and distal phalanges. Alright guys, so let's discuss about please the axial skeleton. Here you can see this is your skull, and this is part of the axial skeleton. Then you can see the cervical vertebrae, total 7 of them. Then you can see thoracic vertebrae, and then the strongest one, the lumbar vertebrae. Then on the anterior side, you can see this is a rib cage attached with the breastbone. This is also called as sternum. So sternum is having the manubrium, then it's having the body, and this is a Z-fired process of the sternum. This is the manubriosternal joint. It's very important landmark, and it's, you can see that located on the second costal cartilage, and this is also called as angle of Lewis or the sternal angle. Clinically very significant because this is the site of the bifurcation of the trachea. This is a site where ascending aorta is changed to the arch of the aorta, and arch of aorta continues as descending aorta. Another important clinical significance of this sternal angle, that this is a junction of the superior and inferior mediastinum. Then it's present in front of intervertebral disc of the 4th and 5th thoracic vertebra. Then you should understand about the sternum that this is one of the common site of bone marrow, red bone marrow, because blood cells are usually produced through these flat bones, the sternums, then rib cage, iliac crust, and then vertebrae. So any person who is suffering from bone marrow cancer, so usually we take the sternum, body of the sternum for the marrow biopsy. This is the common site. Then you can see this is the clavicle. This is the commonly fractured bone in your body, and commonly fractured from this part because this is junction of the 2 ossification centers. On the medial side, you can see this is attached with the manubrium. On the lateral side, you can see this is attached basically with the acromion end. So you can see this is the acromial end of the clavicle, and this is the sternal end of the clavicle. This is the long bone, but this is horizontally placed. Then you can see the ribs, the total, there are 12 pairs of the ribs, and all the ribs are posteriorly attached with the thoracic vertebra. So there are 12 thoracic vertebrae, and we have got 12 pairs of the ribs, but we have got 11 intercostal spaces. So if any person is having another origin of another extra rib coming from the transverse process of the 7th cervical vertebra, so it's mean that rib is called as cervical rib, and that rib is going to cause a lot of trouble, and it's going to compress all these structures like roots of the blood vessels, cords of the brachial plexus, the nerves coming and supplying to the upper limb are going to be compressed in this part. Patient will have weak pulses, weakness of the muscles, also the numbness, the pain. So it's mean that person is having compression of these structures passing through the neck, especially through the posterior triangle of the neck. So that is called as thoracic outlet syndrome or cervical rib. It might be the unilateral or the bilateral also. Secondly, you see this is the intercostal space. So we have got 12 pairs of the ribs and we have got 11 intercostal spaces. All ribs are attached posteriorly with the body of thoracic vertebrae. So you can see that one rib, the head of the rib is basically articulating with both upper and lower part of the thoracic vertebra. So that part is called as demifacet. Demi mean half. So you should understand that ribs posteriorly attach with two bodies of the thoracic vertebra, except the first rib that is articulating with single body, 10th rib, 11th and 12th rib. Except first, 10th, 11th, 12th, all the ribs are attached with upper and lower body of the thoracic vertebra. Then you should understand that first 7 ribs on the anterior side attached with the body of the sternum. These are called as true ribs. Then you have got 8th, 9th and 10th rib. They are attached to the 7th costal cartilage. These are called as false ribs. Last two you can see having no anterior attachment. These are called as floating ribs. And you can see the intervertebral disc also. Sometime any person who is having inflammation, swelling of this disc will have lot of trouble and compression of the nerves roots like in the sciatica also. So you should understand the common site of the disc herniation is between L4 and L5, but in cervical part of the spinal cord or in cervical part of the backbone, C5 and C6 disc is commonly inflamed or the herniated. And then you can see some openings here in transverse foramens. So cervical vertebrae is only those vertebrae which are having basically the transverse foramens. The transverse foramens are clinically very significant because the vertebral arteries, branches of the subclavian arteries entering into the neck and then supplying to entire brainstem structures below the midbrain and also supplying blood to the cerebellum, the hindbrain and to the spinal cord also, passing through the transverse foramens except the C7. I hope you understood. Thank you.